departments. I've been a nurse for about 26 years and kind of an amalgamation of many different nursing environments and business environments. So I am happy that Mira asked me just a few days ago if I would do psych training. And I kind of surveyed a few people to get an idea of where we are, where we want to be. Mrs. Boyda does a great job in her class and has invited me back twice, because I guess I'm a good psych patient, to help with training. Tonight I'm going to hopefully power through the slideshow that's going to kind of give just a background of general EMS and psych. Today when I showed up at work at 8 o'clock this morning, I acted as an EMT. That's not why I went to work. So I got the, Eileen, he's downstairs, he's on the grass, he's in the DTs. They picked me because they know that I'm trained, and all of a sudden a bunch of people are out on our property. I'll talk about that later. It literally was a call. I don't have an ambulance, I don't have a jump kit, but I do have a foundation of EMT knowledge, of getting the fear that's racing in me in control before I meet the patient. And the most important thing to me after I get my fear in control is I know I have 4, 5, even 10 people if I decide to call an alert. We have a process at work whereby they're backing me up. They are there with me. I'm going to be with the patient, and I know if I need anything, they're right there. That helps my fear go from here to here. I'm a trained professional. I'm a trained EMT. Do I get scared? Absolutely. Do I get my fear in control and manage the patient? I do. But it takes some work, it takes knowledge, and it kind of takes some real wherewithal to say, put yourself out there. Because hiding behind or hoping somebody else is going to do it. I just came from my daughter's game. It's a playoff game. It's really close. I'm hoping we get a call. And my message to the girls tonight was, assume nothing. That's Mrs. Boyda's mantra to you guys when you start class. Because the ball's there and 10 people are playing statue softball. You really don't want to get caught playing statue anything in an EMS system, right? Especially with psych. That patient needs to know you're competent, you're confident, and you are going to help them and give them dignity and respect. So this is where I work. This was actually developed, this slideshow, this PowerPoint. We do so much in the community, and New Canaan is there all the time. They were there today. So they do some training with New Canaan EMS. So psych emergencies such as acute psychomotor agitation, suicidality often arise in non-psychiatric settings, such as general hospital, emergency services, doctor offices, and in town, and give rise to stress for all persons involved. Who can attest to that? Do they stress everybody who's involved? No? Yes? They may be life-threatening and therefore be treated at once. Okay. You want to gain overview of the major types of psych emergencies, identify main presenting features of a psychiatric emergency, identify the demands such cases place on the demeanor and behavior of first responders. That's us. To identify, or it may or may not be us, to identify essential components of the successful management of these emergencies. All right, 2 main types of psychiatric emergencies. So they're really taking everything and giving it to acute excitement with psychomotor agitation. That covers a pretty big gamut of your psych patients. Self-destructive or suicidal behavior. That's going to cover another gamut. Symptoms. So these are the things when we come on scene, and Mrs. Boyda tells us within how many seconds did I size up the scene, or should I? How many? Say it. 5 seconds, 10 seconds max, right? So if I can't get that fear that's inside me in control to some degree, I'm going to miss. I'm going to miss what's happening on the scene, because what happens with fear? What happens to our vision? Normally we can see pretty much like 180, right? We're going to get binocular, we might get monocular. Our field of vision shrinks because we're caught up in our own fear. So these are some of the things when you're wide open. Disorientation. We do that all the time. On every single patient, that was the first thing I did today. Where are you? Who are you? Where are you? What's the date? And it took him a while to get there, and he got there. You're disoriented. What is their level of consciousness? Impaired cognition. I want to know what their baseline is, especially on a psych patient. Is this normal for them? Is that what we do all the time? As we go on, we're going to see really psychiatric emergencies are no different than the cardiacs that you all feel great about, and I go, oh my God, I hope I have an EMT with me, because I haven't done cardiac. As a 20-something, somebody drove on a tennis court where I was playing a match. That was my cardiac. They put me in the vehicle and took me to the guy who probably had an aortic dissection. I did mouth-to-mouth on him. He didn't survive. That was my exposure to hands-on, well, no, I should say I did it in a hospital setting several times, but in an EMT situation, that was kind of memory disturbance, delusions. Well, those are fun. Somebody who's really not in touch with things. Hallucination. What kind of hallucination can you have? Visual. I see things. Auditory. I hear things. And those are the questions we ask. You may or may not ask this. Unlikely you will. We ask, do you see or hear things other people don't see or hear? Why do we ask that? It tells us. It's part of our algorithm. And as you get seasoned and more comfortable on these calls, you will start to see the algorithm develop, just like it does with your trauma sheet, just like it does with your medical sheet. Just like you run a CPR code, you guys run it like a symphony. It's a great thing to watch. And by the way, these people know they're having them. They tell me, yes, I see things, and they explain to me what they are. Yes, I hear things other people don't see or hear. Increased drive. That kind of means this cycle with the psychomotor, agitation, elevated mood. You know, they're up at 2 in the morning cleaning. They're not sleeping. They're just, everything is a race. Irritability. Anybody know what that looks like? Me in the morning before I've had my coffee, for sure. Intense fear with autonomic manifestations. What might some autonomic manifestations of fear be? Come on, class. What's your autonomic nervous system? What happens when you get scared? What happens to your pulse? You might sweat, right? That's hard being like this all the time, right? It's very difficult to be in that state for prolonged periods. That's our patience. You might be able to compensate and do that for a short period. For prolonged periods, it's very difficult to stay at that level of agitation and have those autonomic manifestations. Elevated blood pressure, elevated heart rate, elevated respirations. They're sweating, they're anxious, their muscles are tight. Restlessness. Okay. No, you're fine. Keep going. Potential causes. Intoxication. Alcohol or other psychotropic substances. Withdrawal syndrome. This one scares me. This one is one we see with probably somewhat relative frequency and may or may not know it. Alcohol and benzos. Benzos are your Ativan, Klonopin, Xanax, Valium. Those are your top contenders. And when people abruptly stop those substances, they're drinking a pint of liquor every day. I had a guy today he's now 2 pints a day for about 30 years. You stop, you are going to have a grand mal seizure. You might have a cardiac condition. I see cocaine, and I see 20-somethings with serious cardiac manifestations from using cocaine. Dementia. We're not going to go that much into that. I feel like you guys, we do see that. We have, skilled nursing facilities. We have homes here that are housing a population of people with dementia. Psychotic illness. Well, people think it's psychotic illness, and this was sort of an enlightener for me, really. I didn't know you could have a depression that caused a psychosis. You can. We think of prior to knowing that, I thought of psychotic, they're your really crazy people, they're your schizophrenics. Not necessarily. You can have a depression, a bipolar that's causing a psychosis. And it's very treatable. Mania. That was the agitation one that I said. You know when we see mania? In the spring. The sun is out, the birds are singing, and all of a sudden the manics are hot on our phone lines to come in. Depression. Agitated depression, different types of depression. We're not going to get too technical, we're going to know they exist. Anxiety, panic. Those are your ones where short of breath, that might be the call. Ooh, guess what? Do a little talking down. We got a little calming zone. Maybe one person in your face. Maybe I ask you, gather meds, talking with family, get quiet when you talk to your patient. One of the first things I do when I'm training people, we have people call, and they're crazy, screaming in the phone! Am I this? Am I that? And I'm arrested, I'm in jail, you have to! I'm sorry. I can help you if you like to talk. Where should we start? That's what tends to happen as we as caregivers go right up there with the patient. Guess what we did? Agitated patient, no more. So it takes some doing when your heart's racing in your chest. First of all, get the first words out to the patient, and second of all, not to talk to them the way they're talking to you. They might be cursing at you. You might hear language you never heard before. And you have to interface with them. Keep in mind, and I'm going to say it over and over, these people are sick. They have a process that's the same as somebody who's insulin dependent and in a coma, and we have to figure out what we can do to get them from point A to point B. It's no different. Some of it's a little funny, and you'll see some comic relief. And I'm here to tell you, actually, that's okay. Because we're dealing with these people, it's stuff that's just, you can't make it up. You sometimes could not even read it in a book. It's so bizarre sometimes that for me to cope with it, when I'm away from the patient, when I'm with my veteran nurses, and we're saying, oh my God, did you see poopy pants? It's not hurting the patient. It's not meant in a derogatory fashion. It's helping me because I'm having a hard time believing what I just saw, processed, and did. I need to go somewhere and just vent, just like you do after you have a significant medical or trauma. It's no different. Keep in mind where that goes, the confidentiality. Are you doing it because it's so funny and you're carrying it too far? And medications, we're really not going to go into, and it's really for time's sake. I think all of you do a great job of asking people what their meds are, and also what do you take that for. We're going to skip this whole thing. We kind of did a lot of this, so we're sort of covering These are some of the things you might continue to observe. Depression, substance abuse. Very frequently, substance abuse is what we call dual. They're using substances because something's wrong inside that has not been addressed. There's an underlying depression, there's an underlying anxiety, there's an underlying psychosis, there's something psychiatrically impairing them. More frequently than not, the people who are chronic with their use of chemicals, alcohol, drugs, have an underlying psychiatric disorder. So keep that in mind. It's not like just, the drunk on the street. That person is sick, they're impaired, they're disabled, they need to get somewhere, we have to take them. Difficulties with emotion regulation. So somebody whose pet goldfish died is doing a little, bury my goldfish, and somebody else didn't get to school for 2 weeks because their goldfish died. It's like an over the top. So these are some of your key things to look at. Their response to stress is quite different than someone else who's not impaired. Psychosis, self-harm, cutting, burning, hitting, headbanging. You're on a call and somebody's, at the wall banging their head. Number one, you gotta stop them. And number two, that's a sign of some kind of self-destructive behavior. Start investigating because they have long sleeves on. You'd be surprised what you see on arms and thighs. And I always like to know what hand is their dominant hand. Why? It's really hard to cut as a lefty, but they can do it. If you're a righty, you're probably cutting here and cutting here, or burning. Prior history of a suicide attempt or any suicide in their family tree, you may or may not know that, it's just something to keep in mind, raises the bar significantly that they have the potential to complete a suicide. And a prior attempt increases the bar more. More often what's lost is, that was to get attention. That's why she took all those pills. It's brushed under the rug, or it's not getting the proper treatment. 6 months later, we get information they completed. They did it. Somebody says they're going to kill themselves. It's not up to us to decide whether or not they're going to do it or how serious they are. We are not there to diagnose or treat. We're there to transport. If you're a threat to yourself or others, you're going. True? Everybody who's been on Psych calls has witnessed that, right? Okay. We skip this. We skip that. Okay. Psychiatric emergencies are often but not always caused by mental illnesses. What does that mean? That's kind of a tall order, right? They require action without delay to save the patient and other persons from mortal danger or other serious consequences. That's our job, in concert with a number of other people. The police, you're 50 or 51, or what else might you have on a psych call? Anybody? Besides your police and besides your supervisor, what else might you have?
Fire.
What resources available?
Their family?
Their family, but as far as EMS,
Fire.
medic. Keep that in mind. Know your resources, know what's available, and know when you want to make that call. And ask your radio person, we need a medic. And we'll get into that. Immediate treatment directed against the acute manifestation is needed. That's why we have to transport them. This isn't going to get better. And I will frequently say that to a patient or say that to a family who seems to be hedging. If you called 911, guess what? Is this going to get better in an hour? Oh, we don't want to. There's a lot of stigma attached to it. People still have the stigma with mental illness. They have fear of what's going to happen in the hospital. They have a preconceived notion. And then all of a sudden it becomes like, I'm not going to go because I can't have my cell phone there. Your whole world is falling apart. The bottom's falling out. And they're not going to go to get treatment because they can't have their cell phone. Okay, so here's what our essential skills should be, and you guys have these. The ability to establish a stable, trusting relationship with the patient. Do you guys feel like in general you have that on the calls you go on? On your medicals, on your traumas? You feel a little bit less like that on your psych? Maybe a little less? Psych is hard. You don't have an established algorithm. There's too much with the unknown, and there's fear that goes along with the unknown. It's really no different. They're sick. They're acutely sick. They need to go from point A to point B. It's our job. No different than any other call. You've got to keep that in mind. The ability to talk down. Anybody know what that might mean? An agitated patient. What does talk a patient down? Come on, guys, you know this. It's not talk down to the patient. Like, what's wrong with you? Get up and get going. That probably would not be good. John.
Like if they're yelling and kind of screaming at you, you want to kind of calm them down and talk about it.
How would you do that?
Well, like you said, don't yell back at them. Use calm words, treat them how you want to be treated in a nice, polite way, and respect them and let them kind of say what they want to say and get it all out.
Right. Same thing you would on any other call. Sometimes we have a lot to say. Be careful, because you could be opening Pandora's box, and I really don't need to hear what happened in second grade, and you didn't get the last piece of pepperoni pizza. I really don't want to hear it. I want you to go from there to there. So if we start in second grade and you're 50, oh my God, that's way too long. I'm going to be making so many calls about why I'm prolonging my scene time. A rapid and unambiguous decision about treatment, including consideration of available options for effective pharmacology. That's why they go to the hospital. They are so sick and so decompensated. The only way that they're going to get treatment and the manifestations of their illness are going to improve is with medication. And sometimes it starts as IV, because they are so severely impaired that they probably are going to get an IM and/or an IV to start.